Hello, and a very, very warm welcome from Basel, Switzerland, where we are in our webinar studio tonight to this exceptional webinar about clinical advantages of platform-switched CONELOG implants with a promote surface and a deep conical connection, and somebody who is I really appreciate a lot, Professor Juan Blanco from Santiago de Compostela. And Professor Blanco, he graduated in medicine in 1986 and in stomatology in 1988, both from the University of Santiago de Compostela. He has a master in periodontology from the Complutense University in Madrid, and he is professor and chairman of periodontology at the University of Santiago de Compostela since 2008. He was as well the president of the Spanish Society of Periodontology from 2007 until 2010, the chairman of the ITI Iberian section from 2010 to 2016, the president of the European Federation of Periodontology in 2017, and he's still a member of the ITI Research Committee. And really, Juan, what a nice evening to have you here. How are you doing?
Fine, perfect. I'm perfect. I'm looking forward to starting this webinar and showing you all my experience with this, in my opinion, important device. Let's say device.
Yeah, we are very much looking forward to it. Just before we start, I would like to mention something. When you have questions, please be so kind and use in your screen, you have the F&A button. So don't use the chat for your questions, just refer to the F&A button. When you click there, a window opens and then you can ask your questions and we will answer the questions after Professor Blanco's presentation. So please, Juan, the stage is yours and we are looking forward to your presentation.
Okay, thank you very much, Michael, for your kind introduction, for your kind presentation. It's for me a real pleasure to be here today to talk about my experience with this interesting implant. And also, I would like to thank to all the team that is behind this by Horizons CONELOG. And also, I would like to thank to the Oral Reconstruction Foundation team for sure, for inviting me to be here today. The topic, as you have just said, Michael, is about the clinical advantages of platform switch CONELOG implants with a promote surface and conical connection. So let me introduce the topic, talking about a little history about implant dentistry, because in my opinion, there is something very important as clinicians, is that everything probably is already written. The only thing that we have to do is to go to the literature and to read the papers. However, very important to understand the evolution of the treatments that we do today in our daily practice. And clearly in implant dentistry, there were an evolution from the treatment of the first patients that they were fully edentulous. Afterwards, the next patients that were treated were the partial edentulous, and finally the single unit. And everything step by step until we could treat the single unit gaps. Of course, there were different concepts that were treated in those years. Osseointegration concept, the functional ankylosis concept, and also the discussions that we had at those years with the submerged and non-submerged implant dentistry. But there was a moment, a very important moment in implant dentistry that was in the mid-80s and also in the early 90s, where bone regeneration and periodontal plastic surgery appeared. And with these two concepts, with these two clinical applications, we could have the advantage of having a better aesthetic results with our patients. In fact, not only aesthetic, but in those years, very important to understand that the survival rate for full edentulous was better for the mandible than for the maxilla. In those days, probably the most or the more implant used was the machine implants, as you all know, probably know, with different survival rates in different indications, and also not only in the full edentulous, but also in the partial edentulous, with very similar survival rates with this type of implants. However, from the year 2000 on, clearly our patients want to have aesthetic results, but not only aesthetics, but also long-term aesthetic results, and probably in the shortest time possible. This means immediacy. And with this in mind, it's very important that not only the companies, but probably scientists, it's very important that we have to understand that new surfaces, new designs of the macro design of the implants could change, and also, why not, materials. The only thing that we should do is to have a better knowledge when we apply these differences in the surfaces and designs of the implants, particularly how they behave in terms of biology. And with these different surfaces, we can understand and we know clearly that not only in the short term or medium term, but also in the clearly long-term results, but because our patients need to have good results in a long term. This means 20 years with the TPS, the classic TPS surface, we had important survival rates, and also with another kind of surfaces with also, again, important survival rates. However, we have to understand and to be aware that new surfaces had the advantage of improving clearly the success rate and the survival rate in the long term in our patients. In addition to this, once we understand the different kind of surfaces and also the micro design of our implants, is clearly that we have to, of course, use these clinical applications of these new materials and surfaces in terms of immediate loading, immediate implants, and why not both together, immediate implants and immediate loading. Having said this, I would like now to introduce you the objectives of this webinar. Very important to understand the long-term results and the influence in these long-term results of the surface that is called promote surface. Very important to understand the scientific evidence of this system, the CONELOG system, and how important is the transgingival component of this system. The new implant design that is called the progressive line implant. And finally, I will show different clinical cases with the application of this new implant design. Let's talk about then the long-term results, generally speaking, of the CONELOG system. Clearly, I have just said before, these moderate surfaces in the implants, clearly from a preclinical, and not only preclinical, but also clinical studies, have shown us a better and faster bone apposition, and also a better and clearly improving of the survival rates and also the success rates. And we have here in this slide the two images of the CONELOG screw line and also the CONELOG progressive line, and why not the evolution of the different type of designs of these CONELOG systems, starting in 1999 with this promote surface. And this promote surface is characteristic because it's a moderately rough surface, and is also prepared with a sandblasted and acid etched technology. This means that it's very similar to the SLA surface characteristics from the Straumann system. And there are different kind of research from a preclinical point of view, in vitro studies, preclinical in vivo studies, and also clinical trials that show us that this promote surface, this kind of surface in different types or kind of CONELOG implants, and in different clearly countries, the survival rate and success rates are very high, both of them in a long-term run, as you clearly can see in the different studies with the different term. Also, let me talk about very recently published papers. This is a 5-year post-loading results of an equivalence randomized clinical trial. And this randomized clinical trial was done to check this platform switching, the relevance of this platform switching. The randomization was between this platform switching with this platform matching. It was a randomized clinical trial with 60 patients treated and 128 implants at 5 years term with the CONELOG screw line implants. And clearly the objective of this study was to compare these two different platforms, the switching platform and the matching platform in this kind of implants. And in these X-rays images, we can see the follow-up. This is the loading, the 1-year follow-up, the 3-year and the 5-year. This is for the switching platform. And here we can see the same result of the same images with the same follow-up, but in this case with the platform matching. And at the end, the results were better, a little bit better, slightly better for the platform switching than the platform matching. However, no differences in survival rates between groups. And the most important result was that after 5 years of functional loading, a slightly better results in terms of a marginal bone level preservation was for the platform switching abutment. So the conclusions is that a slightly benefit from the use of platform switching. However, there were an important per-implant marginal bone level between two platforms without clinically relevance and no differences in survival rate either. The next paper I want to share with you is a paper that the study design is what is called the non-interventional study. This kind of a study are done in different private centers or in different centers where different professionals intervene with the different indication. They can do it freely in terms of that they can treat whatever they want, the different indications, and again, 5-year results. And this is very important, this kind of study, because this is the reality. Because in this case, 17 clinics, private centers have treated different patients, 196 patients with almost 300 implants checked with the CONELOG screw line implants. And the aim of this kind of study is always the same, is to check the survival and success rates and the general performance, in this case with this CONELOG screw line implants in clearly daily dental practice. And the results were very important in terms of success rate, according not also to the success criteria by Albrechtson, but also to the success criteria by Danny Busser. And the results, as I have just told you, were very high. And this means that the crestal bone loss was minimum, 0.20 or 0.3 millimeters from loading to 5 years. And important to say is that almost 40% of the implants showed bone maintenance or even bone gain, as you can see here clearly in the graphic. 99% of the patients were satisfied or very satisfied. So clearly the conclusion with this kind of implants is that in daily clinical practice in the private setting, excellent clinical outcomes with highly satisfied patients after 5 years of function. This confirms the results of the different randomized clinical trials that I have shown you. So in terms of long-term data and the influence of this surface, is clearly that the evidence in the literature support this kind of implants. Let's move now to the evidence of the second implant design. This is the CONELOG system. And in this kind of implant, it's very important to talk about the relevance of the transgingival component. So let's start with 2 clinical studies. The first study is a case series study that this was done only in 2 centers. It's important to understand that the study design is very different, for example, of the previous one where were participating 70 centers. In this case, only is a 2-center study, a prospective study for sure, and the follow-up is again 5 years. The number of patients is less, 24 patients, 52 years implant with this new implant design. In this a paper has been very recently published this year, and the results, or sorry, the aim of this study is again to check the long-term results of this CONELOG screw line, and this is with a follow-up of 5 years. And the survival rate and the success rate was very similar, as you can see here in the figures. And the relevance or the importance of this study is clearly that this kind of implants was installed in 3 different positions: subcrestal, epicrestal, and supracrestal. And what is important to say is that when we place the implant slightly subcrestally, never the implant surface is going to be exposed. However, if we go for the epicrestal or the supracrestal, at the end we are going to have some quantity of rash surface exposed. However, if we go to the data, clearly when we install the implant subcrestally, we are going to lose a slightly higher bone than when we compare it with the epicrestal or the supracrestal. In fact, in these cases, some bone gain was obtained, but the important difference is that in these cases, the rough surface was exposed. However, in this situation, the rough surface was not exposed. And this is very important, as you know, for the long term. So the conclusion is that the results were successful in terms of function, in terms of clinical results, radiographic outcomes with this internal conical connection after 5 years of loading with an important stable marginal bone independent of the initial crestal position. So this means that independently where we are going to install our implant in relation to the crestal bone, we are going to be able to keep that per-implant crestal bone. However, remember that if we leave the implant slightly supracrestally, we are going to have some rough surface exposed. The next study in this case is again a non-interventional study with 94 patients, 130 implants with this, again, CONELOG screw line implant with a mean follow-up of 3 years, between 2 years and 5 years of observation period. And again, as I told you before, the non-interventional studies to check the success and the survival rate in different clinical scenarios in the different private clinics, and also to check the aesthetic outcome in this case. And important also today is to check the PROMs. This means the patient-related outcome measurements. Therefore, the patient satisfaction of this treatment with this CONELOG screw line implant. What about the survival and success rate? Both figures were the same. Survival and success rate before loading was 98.4%, and after loading 100%. This is because a minimum bone loss was appreciated along the different periods of observation, as you can see clearly here. 0.52 from surgery to loading, and almost nothing in the long term, in this case, 3 years of term. Patient-reported outcomes, these variables that are called PROMs, with an important success of the results coming from the patients. The patients were clearly satisfied and maximal satisfied with this treatment, with these results. And again, this study, this non-interventional study, demonstrated in a daily dental practice the successful functional and aesthetic outcome with this CONELOG implant. And now let me talk about the relevance, not only from a conical point of view, the internal connection that clearly has been demonstrated, that this internal connection, and in this case with 7.5 degrees of connection with this CONELOG implant. Very important to say that the in vitro studies, when we check clearly the microfiltration of these two connections, clearly the internal and conical connection is much better than the other ones. Also, we have already talked about the platform switching, that we're able to preserve more bone when we use a platform switching abutment. This discrepancy between the abutment and the shoulder of the implant, but also very important, the surface, very important, the connection, disconnection, the contamination, the height of the abutment, and also the shape and use original devices. Let's talk about two important aspects: the connection, disconnection, and afterwards the height of these abutments. Because when we manipulate this abutment, and let's go to check to see this figure, histologically we can see clearly the sulcular epithelium, the junction over rear epithelium, and clearly the connective tissue on top of the shoulder of the implant. And here is the bone where it has to be. If we manipulate this abutment, clearly we are going to disturb this healing. It's like, for example, if we go to the tooth and we cut the tooth or mill the tooth or prepare the tooth, and we invade this clearly biological width. So it's very important to keep it in touch and not to disturb it. However, when we manipulate the abutment, clearly we are going to produce a bond here, and a bond clearly has to heal. And this healing means that from a biological point of view, this epithelium is going to downgrowth, and clearly this connective tissue is going to be positioned a little bit downwards also, and the clearly problem that we are going to have is bone resorption, and then exposure of the shoulder of the implant. This means the crestal bone loss is going to appear. So let's talk about the connection, disconnection first, and then the relevance of the height of the abutment with different studies that we have already done in our university. The first one is this study that was a randomized clinical trial that was started in 2011. And this study was to evaluate the outcome of this new, in that moment, CONELOG screw-line implant. And we were going to check the connection and disconnection of the abutment. This means that we check the immediate abutment installation. This is what is called today the one-time, one abutment approach versus the delay abutment placement. This study was done in 2 centers. As I have just told, it was an RCT, a design that clearly checks the efficacy of the system. In this case, the immediate or the delay abutment placement in 2 centers, in our university and also in the University Complutense of Madrid with Professor Sanz. The material was this implant with different diameters and length, and also the abutments that at that moment the CONELOG company had for this implant, this CONELOG implant that was the Vario SR abutment. This is clearly the implant design with all the wrap surface to the top of the neck. And this was the design of the Vario connection of the Vario abutment. In this study design, the primary outcome, as you can imagine, was the evaluation of the crestal bone loss between the two type of healing approaches and several secondary variables such as the implant survival rate in the long-term, assessment of the soft tissue, performance of the restorative components, the problems, the patient satisfaction, and adverse events. And this was the study, the randomization. We installed the implants in one group. We went for the healing abutment, and in the other group, we went for the definitive abutment. So in this case, we had to connect and disconnect this abutment for going finally to the prosthesis. This was not the case of this situation because we installed the abutment at the same time of the implant installation with the one-time, one abutment approach. Finally, 6-12 weeks post-surgery, the prosthesis was installed within 2 weeks after this period. I'm going to show you 2 clinical cases that were done at those years. Between 2011 2012, we proceed for doing this study. Clearly, we can see a good bone availability in this posterior zone of the mandible. We installed the 2 implants. In this case, with the one abutment, one-time approach, this was the healing cap on top of that abutment. You see here the day of the surgery, the day of the impression taking, and this is how the case finished. Loading, 6 months of follow-up and 12 months of follow-up in this case. The second case that I'm going to share with you is the other group, the group A, with the healing abutment installed in the day of the surgery. Finally, we went for the impression taking and finishing with the loading. You can see here the crown and the loading x-rays, and then the follow-up at 6 months and also at 12 months with minimum bone loss 1 year later. And this study led to this publication in 2016. So important to understand that when we do surgery and when we do research, this research is not immediately published. This was a study that started in 2011, 2012. However, the 12 months follow-up was published 4 or 5 years afterwards. So it's very difficult to do a perfect randomized clinical trial. It takes time. It takes many variables to keep under control. So in this 12 months follow-up study, we could obtain in the two centers, our university and the Complutense of Madrid, a 98.3% survival rate. And the most important aspect is that when we compare the healing abutment with the one abutment approach, clearly from loading to the 6 months of follow-up, we were able to keep a better crestal bone loss when we go for the immediate abutment installation. So the conclusions is that the connection and disconnection of healing abutments is associated with significantly increased bone loss during the healing period between implant placement and 6 months post-loading, as you can see clearly here in this table, when compared to the one abutment approach. But important is that the other day, 1 month ago, when I was invited by the CONELOG company and the ORF Foundation to give this webinar, I went to our records in our university and I was looking for our patients, and I could find 5 patients with important follow-up that I'm going to share with you just now. This is the 6 months of follow-up of this patient, 12 months of follow-up, 24 months of follow-up, until in this case 7 years of follow-up, because as I told you, this study started in 2011, 2012. So I have follow-up of some of the patients until 7 years. And you can clearly see that the bone loss is maintained, is kept in the same place as it was 6 months follow-up. Let me share with you another case. This is 2 implants with 3 units prosthesis with a 3-unit bridge. And again, clearly at 7 years follow-up, we can see that the bone is still there. So this means that this system, this surface, this implant, this technology works in the long term. Again, another case, and we can compare the 2 implant system, and they are able to maintain, both of them, the crestal bone. So this means that both systems clearly work, and probably the surface is very similar, as I have told you before when I was talking about the promote surface. Again, another case. This is, I was able only to find X-rays until 5 years follow-up. And again, you can clearly see that this system is able to maintain the bone where it has to be. And the last case I'm going to share with you, this 5th case, again, look at this, how stable is the crestal bone on this type of implants. So in terms of one abutment approach, clearly from loading to 6 months, there is the possibility of maintain and to keep more bone when we use this one abutment approach. However, in both cases, we are able to keep and to maintain this crestal bone level in the long term, not only 12 months, but also in some cases, as you could see, 7 years, and other cases, 5 years. Let me show you another RCT that we have done in our dental school, in our university. Is about the height, the relevance of the height of the apartments. And I'm going to tell you this because finally, when I finish my presentation with the cases, I will show you the way I proceed today with the implants in my patients. And this is based in our own research and for sure the research that we have today in literature. This first study was for comparing these two apartments. This has been done with another implant system that is not relevant. The relevant is that the randomization was here to use a 1 millimeter abutment or a 3 millimeter abutment. And with this clinical scenario where the mucosa thickness is 3 millimeters or even more. And in these cases, we can use a 1 millimeter abutment with no problem because we have 3 millimeters or more of a mucosa thickness. And in this case, the 3 millimeter abutment, again, we can use it because it's not going to be exposed because we have enough mucosa thickness, as you can see. These were these two clinical scenarios, and the primary outcome was to check this bone loss that we are going to have in this case in comparison with the other clinical situation. This is the primary outcome, as I have just told you, comparing the bone loss in the 1 millimeter abutment with the 3 millimeter abutments. And clearly, I'm going to show you these two cases where we have installed the implants equicrestally, bone level, as the company advise us, recommend us. We can see here the shoulder of the implant represented by the blue line, and the red line is the shoulder of the implant with a 1 millimeter height of abutment. And here is the 3 millimeter height of abutment. This is the day of implant installation and abutment installation. And after the follow-up, we could see here a bone loss in this 1 millimeter height of abutment. However, in these other implants, we were able to keep and to maintain stable this crestal or per-implant crestal bone. And this is the important figure here, that clearly with this 3 millimeter abutments, we are able to keep this perimucosal seal clearly maintaining in that situation with this height of the abutment. And if we go to the global data with the global figures, with the long abutment, almost we didn't lose anything bone. However, with the 1 millimeter, this short abutment, we have lost almost 1 millimeter of bone loss. And this difference was clearly significant when we compare statistically these two groups. However, we went for another RCT, again, comparing the two height of abutments. However, in this case, with a different clinical scenario, we are going to have a thinner mucosa of 2 millimeters or less in two clinical scenarios. This first scenario was the 1 millimeter height of abutment, and this second scenario with the 3 millimeter abutment, we cannot put it on top of this implant because the abutment was going to be shown on top of the mucosa. From a statistical point of view, this is not allowed for by our patients. So we have to go a little bit deep subcrestally with this implant, and afterwards, and now we can use this 3 millimeters height of abutment. Clearly, we are comparing in this thinner mucosa two clinical scenarios, the one with the 1 millimeter height of abutment and the second one with the 3 millimeter abutment, but the implant was established, was installed a little bit subcrestally to be able to install this 3 millimeter height of abutments. And when we go for the comparison, we have, this is the same group as in the first study, bone level implant, 1 millimeter of abutment, as you can see here, but in this case with a thinner mucosa. In this second scenario, we install subcrestally the shoulder of the implants to be able to install this 3 millimeters height of abutment. And what were the results in these cases? When we install subcrestally, we are able to keep the bone on top of the shoulder of the implants. This means that we are not going to have any rough surface exposed. However, if we go to this second scenario, we are going probably to have the same or similar bone resorption. But the problem here is that we are going to have rough surface exposed. This means peri-implant crestal bone loss. And here we don't have any peri-implant crestal bone loss, keeping the osseointegration protected with this 3 millimeters height of abutment, and what is more important, the soft tissue, the peri-implant or peri-abutment mucosal seal. And these are the figures of the global result. In the long abutment, almost nothing. We couldn't find any bone loss almost. However, in the short abutments, we found almost 1 millimeter of bone loss. And this difference, again, was statistically significantly different. And in addition, I have to say that when we made a secondary analysis of our X-rays, we could find in some cases, bone on top of the implant shoulder. And in no case in the abutment height of 1 millimeters, and almost in 50% of the cases when we had used this 3 millimeters height of abutment. So two important observations. The first one is the efficacy that the RCT brings us, is that it's important to go this protocol using the 3 millimeter height of abutment when we have 3 millimeter of thickness of mucosa or more. We can use or we can install the implant, the shoulder of the implant, in a bone level situation. However, when we have a mucosa, a thinner mucosa, we have to go a little bit subcrestally. And in those cases, we are able to find almost in half of the clinical situations, 50% bone on top of the shoulder of the implant. So the conclusions of these two RCTs is clearly that we should use always an abutment of 2.5 or 3 millimeters of height. When we have 3 millimeters or more of mucosa thickness, we can place the implant equicrestally. However, when we have less than 3 millimeters, to install an abutment of this height, we need to go with the implant slightly subcrestally, or even in some cases, we should increase the mucosa thickness. And in these cases, when we go for the increasing of the mucosa thickness, we can install our implant equicrestally. So next step is, what about the progressing line implant? The progressing line implant clearly is a progression, let's say, of the CONELOG screw line with a modification of the macro design of the implant. And this implant was launched in 2019. And the important aspects of this implant in relation with this other implant clearly is that it allows us to go for immediacy. That is what the patients ask us for today. So with this implant design, it's easier to obtain a higher primary stability because the characteristics of the implant allows us to do it. So if we are able, because we have the device, we have
A test of English, no, I can.
we have a good implant, a nice surface. We have a perfect macro design of the implant. We can go clearly for this immediate implant installation and immediate loading. The characteristics are, again, here, the distance between the threads of the implants, and not only the distance, but also the length of the different threads. Also, different straight abutments. These are called comfort abutments. And in my opinion, as I have shown you with these two RCTs, the abutment that we should use is the 2.5 millimeters length of abutment to maintain and to keep this epithelium and connective tissue on top of the shoulder of the implant, and also going for an immediate abutment installation, let's say the one abutment, one time approach. And the only literature that we have today, because this implant was launched in 2019, is the experience of this clinical report, is that in a 1 year clinical follow-up after treating 72 patients with 166 implants in different clinical in situations, this implant survival, or this survival rate with this implant technology was 100%. But we have to be aware that is only 1 year of follow-up. This probably is from a scientific point of view is not enough. We need to go on researching, this is clear, but we have clearly the follow-up, the long-term results of the surface, the promote surface, and also this CONELOG implant that I have just shown you. And finally, I'm going to proceed to show you different clinical cases, and I hope it creates, or these cases create, some doubts and some discussion afterwards that I will be more than happy to answer and to share with you the discussion. The first clinical case is this patient that was treated 1 year ago, was treated in November, and this was done in ORF course. And this patient has, as you clearly see, 2 single gaps, 2 absents, the 36 and the 40 and the 46. From a periodontal point of view, nothing to say. The patient was under control, was clearly maintained, very well maintained. Different clinical views, the occlusal in the maxilla, the occlusal view of the mandible. Clearly the healing of this 46 was still ongoing, and in this case was the zone that was going to be treated at that moment 1 year ago. This is the preapical X-ray. This is a very easy case, as you are going to see immediately, because the CBCT scan and the bone availability in this case is enough, is good enough for install in a, let's say, an easy way, in a straightforward situation, an implant. The only aspect that we could refer in this patient was the collapse here in the buccal aspect that was going to be treated with a new membrane, collagen membrane, that appeared 1 or 2 years ago, that is called the Novomatrix. This is the bone availability, the situation where we were going to install the implant. Clearly, an important quantity of bone. This is the intraoral scanner, where you are going to see the collapse here, the surgical stand that we have that we have prepared at that moment, and this is the surgical stand before going to the surgery. And 1 year ago, this surgery was done. We have done this surgery. I'm going to show you immediately. I'm going to go a little bit fast because it's not very soon. This is the patient, that's me. Was 1 year ago. Remember that the COVID was at that moment in a real, in an important situation. I'm going to show you immediately the surgery. This is the novomatrix membrane that has to be prepared beforehand in introducing saline. This is the surgery in the number 36. We go for the incision. We lift the flaps, the buccal flap, as you can appreciate in the video, and also the lingual flap. We clean everything and we go with through the surgical stand. We go for the implant installation. Clearly you see that we proceed with the surgical stand with the different parts according to the manufacturer. We check the depth again with the parallel pin to check the distance, to check that everything goes well. Finally, we also control with the surgical stand the position of the implant. Everything, as you can see, is perfectly under control. We go on with the surgery. We go with the different drills to the pre-established depth to install a 3.8 millimeters of implant width or diameter and 11 millimeters of length. This is the implant, the progressive line, the new implant design that has been launched 2 years ago. This is the implant installation, the progressive line, 3.8 diameter and 11 millimeters of length. And as I told you, I go a little bit subcrestally, 1 millimeter, 1.5 millimeters. And finally, I go with the definitive abutment, this straight contour abutment of 2.5 millimeters of height. We eliminate the implant transport or implant transfer. And clearly you see here the position of the shoulder of the implant. We have to increase the hole because the abutment is a little bit wider than the neck of the implant. The abutment diameter is 4.3 and the implant is 3.8. So we need to open a little bit the crest, and then we proceed to install immediately the abutment. And depending on the torque of the implant, we go with the final torque that is 30 newtons, or we have to keep the abutment with less torque than the one that is the definitive torque. In this case, we could obtain the final torque, as you are going to immediately see, because the racket bends, as you can see there. We install the healing abutment. on top of the definitive abutment. And in this case, finally, we prepare this novomatrix membrane to increase and to avoid and to eliminate the buccal collapse that the patient had. This novomatrix has a 1 millimeter of thickness. We prepare this novomatrix. We make a hole in the novomatrix and to use it as a punch on top of the implant, and partially the lingual aspect is covered with this novomatrix, and the rest is put it on and installed in the buccal site, as you are going to see immediately. This is to increase, as I've told you, the buccal convexity, to eliminate the concavity, and if it's possible, to increase the keratinized gingiva. Finally, we go for the suture, and this is the X-ray after the surgery. 1 month post-op, where you can appreciate the healing, and this is the final crown that was an implant was installed according to the pre-prosthetic, the pre-treatment plan according to the prosthesis design. And look at this image where we can see a slightly convexity here. And the important issue is how thick is the buccal aspect here. This is the before image, and on the right you can see the after image. This is the buccal aspect, and this is the lateral view where we can see that there is no collapse here. And again, 6 months post-loading, you can appreciate the keratinized tissue there. And look, 9 months post-loading, this is 12 months post-surgery, because the patient was treated in November last year, and this was done this month. Look at the keratinization of the tissue and the maintenance of the peri-implant crestal bone. And on top of the shoulder, we can appreciate that there is some bone. The second case is a case that we have done in September, this last September, and this was done also for a live surgery for the meeting, the global regeneration meeting that we held here in Santiago. This was a patient, a young patient around 25 years old, with absence of the number 13 and also the 23, because these patients had the 2 canines included, and after extraction of the canines, because was not possible to place them with orthodontists in the place. So we proceed to extract the canines and to do, as you can see here, alveolar ridge preservation after the extraction of those included canines. We had a collapse here, and as we all know, it's important to increase the volume here to avoid this collapse. And in this case, again, we are going to proceed with a progressive line implant, and this is what we want to obtain after the surgery, after treating this local defect. Bone availability, again, nothing to say, but the problem is that the implant is going to be installed slightly buccally, because it's where it has to be. So we are going to proceed and to install the CONELOG progressive line 3.8, again, 11 millimeters, and also the definitive abutment of 2.5 millimeters, as I have told you with the different literature that I have shown you before. This is the final position of the implant that we can anticipate with this design software program, and we need to increase this buccal bone plate to avoid resorption. This is the front view, and with this biomaterial and also with this novo matrix, we are going to go for the GBR guide bone regeneration in a double way, using this minerals mix with AlpureF. This is the AlpureF block, mixing AlpureF membranes with this hydroxyapatite, these minerals, and also using this novo matrix membrane on top, covering this AlpureF block to have the double effect, the barrier membrane effect, and also to increase the thickness of the gingiva. This was done in September, as you could appreciate, and this is the 3 minutes of video. Is going to go fast. This is again always with the surgical stent. We are measuring everything, the final position of the implant, not only in the apical position, but also mesiodistally. We proceed again through this surgical stent with the different bars. We check the distance to the neighboring tooth. And finally, we go for the final depth. And once we finish the osteotomy, we are explaining that here in this collapse with a thin buccal bone plate is necessary to increase the volume of the bone. We install the implant, the 3.8 implant, progressive line, 11 millimeters of length, and again we proceed a little bit subcrestally because we need to leave the shoulder of the abutment at least 1.5 millimeters below the gingival margin, below the future gingival margin. So we install the abutment, one abutment approach, and now we proceed for the cortical perforations for going to the GBR technique. We decorticate the buccal plate. We measure the distance just to trim and prepare the membrane. In this case, this new collagen membrane is the novo matrix. And again, we trim the membrane to perfectly adapt it. This is the AlpureF block. We install the AlpureF block on top of the defect. We prepare and pack this AlpureF block perfectly. We check the membrane if everything is okay. After trimming the membrane, we fix it with pins, titanium pins. On one side, on the other side also, is already installed. We are going to put it a little bit deeper. And finally, we use these AlpureF membranes on top of the novo matrix, as you can see here in the image. And this membrane has the double effect, barrier effect, and also to increase the thickness of the gingiva. We release the flap, cutting the periosteum in the apical part, and finally we suture everything. And you see here the final result. With this, we go for the prosthesis. This is the X-ray after the surgery. And with the prosthodontist in this case, we went for immediate loading. We installed the crown is a screw retained crown on top of the definitive abutment. Here you can see the final result, where it's very difficult to appreciate the bone gain here. And this is important to check it, because I'm going to show you the X-ray 1 month later, and you are going to see the difference in this implant. This is 10 days after the healing. Look at the healing. And this is 1 month after the healing. Everything is perfect. Look at the gingival margin. The gingival margin, the prosthodontist has to put a little bit apical. That is clear, with the different types of provisional prosthesis that have to manage. And look, 1 month later, the difference of the X-ray. This is immediately after the surgery, where it's difficult sometimes with this ALPRF to appreciate the bone here. However, 1 month later, clearly the calcification and the transformation of this ALPRF block into bone clearly is appreciated in this CBCT scan with only 1 month apart. I'm going to show you now the this same patient, the number 13. In this case, there was a higher defect in terms of not only vertically but also horizontal. So again, we lift the flap, we measure everything. We can see clearly that we have from here to the bone 3 millimeters, but we have to anticipate that we are going to use a 2.5 millimeters of abutment. So if we want to leave this 2.5 millimeters of abutment 1.5 or 2 millimeters apart from the future gingival margin, is necessary to go a little bit subcrestally with our implant, 1 millimeter at least. We go for the surgery in the same way I show you. I've shown you in the number 23. Again, the osteotomy with the different drills. We proceed for the installation of the implant, and the implant has to be deeper, has to be deep enough, depending on the length, the height of the final abutment that I'm going to install here. So I have to measure the final position of the shoulder of the implant, that probably has to be 4 millimeters from the crown, the final crown. As you can see here, this is the shoulder of the implant, 4.5 millimeters from the final crown. Now I go for the installation of the abutment, and I leave the shoulder of the abutment 2 millimeters, 1.5 millimeters apical from the future gingival margin, or apical from the apical part of the crown. We again proceed for the incision in the periosteum to go for a coronally advanced flap, and also with the ALPRF, the same technique as you saw in the number 23, the ALPRF block, again with the membranes, the ALPRF membranes. Look at the image from a buccal point of view, the quantity of volume that we can gain immediately. This is the suture, and we go for the immediate installation again. We go for the definitive, the X-ray after the surgery, and here you can see the provisional crown and the implant immediately loaded. And look at the X-ray now. The X-ray in this case is a little bit, and this is immediately after the surgery. And I don't have any, because this surgery has been done 10 days ago. and look at here the importance increase of bone that we can see. Probably we are going to have a collapse, but for sure we are not going to have the initial buccal bone plate. We are going to obtain a better buccal bone plate as we saw in the other tooth in the number 23. And the last case, I'm going to show you a case that has been treated, if I'm not mistaken, some months ago. The surgery was done around May, April, and this case is already finished very recently. This is an almost fully edentulous patient in the maxilla. You can appreciate the bone availability. This is the denture was trying to check the kind of prosthesis that this patient is going to receive and doing the treatment plan according always to the prosthesis that the patient is going to receive. We accept that denture was trying in, and we go for the surgical stent, in this case with barium, to check it, the final distribution and position and location of the different implants that we are going to install in these spaces. We can check the availability of bone in the different situations, and clearly in the posterior zones, the bone availability in terms of height is not very, very important. However, we went for the placement of 7 implants in this patient. As you are going to see immediately, this is the final surgical stent that we are going to use, and also this surgical stent allow us to go for the immediate loading. This is going to be the provisional prosthesis that is going to be installed immediately after the surgery of the implants. We install the implants, the different type of implants, all progressive line, some of them 13 millimeters of length, some of them 11 millimeters of length, the distal aspect 7 millimeters of length, all of them 3.8 millimeters of diameter. We have to check that all the implants are perfectly installed according to the surgical stent. As you can clearly see in these images, this is after the abutment installations, the one abutment, one time technique, 2.5 millimeters of height, and these are the healing abutments on top of the definitive abutments. This is after the surgery, and immediately the patient goes for the prosthesis installation according to this protocol. These are the provisional abutments that are going to be installed for the provisional prosthesis on top of the definitive abutments. Clearly, you can see here the provisional prosthesis, the x-rays, checking that everything is fit and everything is under control. This is the rubber dam that is placed on these provisional tubes that separate the surgical aspect from the prosthetical aspect. The restorative dentist is preparing the final provisional prosthesis. She has to trim and to polish all these remnants, all these rough aspects that has the provisional prosthesis. But I have to say that this is the same surgical stent that I have used during the surgery. And this is the final aspect of the final provisional prosthesis. The 7 implants that are placed, 7 millimeters, 11 millimeters, 13 millimeters, and again, 7 millimeters. This is 7 days post-op in the suture removal. Look at the gingiva after 2 months of healing. And from here, the restorative dentist proceed to the final restoration, and this is the final aspect of this patient. The front view and the occlusal view, where you can see clearly that is a screw retained prosthesis. This is a close-up vision. And these are the final X-ray control, where we can see again that the crestal bone loss is in most of the cases on top of the shoulder of the implant, and always the same protocol. Good primary stability, platform switching, one-time, one-abutment technique with an abutment of 2.5 millimeters of height. And with this, we can go for an immediate loading, and finally, we can obtain these nice results. And these results for sure is not in a very long term. However, with the literature that I have shown you, clearly we can anticipate that the results of these implants are going to be at least as good as the CONELOG system that I have shown you in some cases for more than 5 years. And with this, I finish my presentations. I think I'm on time. But before finishing, as I always do, I would like to thank to our university, also to the University Complutense of Madrid for the participation in that study that I have shown you. It's a very well referenced paper in the literature in terms of connection and disconnection. Also to the group and the team of our dental clinical practice in private practice. And finally, I would like to show you my last slide, is that I come from Santiago. For those people who are not from Spain or from near Spain, Santiago is right here in this corner on the east, on the west of Spain, sorry, on the west of Spain. This is the Atlantic Ocean. Here is Santiago de Compostela, and it's very famous for several things, but an important issue for people that is from abroad, you would read something about the Camino de Santiago, that is called the pilgrim route. Other people call this pilgrim route the way. So probably the way is to go on working, to go on researching, and to find the best results for our patients, always from a clinical point of view. This means that research has to be translated into daily practice. So with this, I finish. I give the word again to our moderator, Michael Nakmus, and thank you, all of you, for your kind attention.
Juan, Professor Blanco, thank you very much for this very comprehensive evidence-based presentation on CAMLOG, CONELOG implants with the promote surface, and as well the conical deep connection, especially on the CONELOG screw line and progressive line implants. Very interesting and really evidence-based. And we know that this is the way to go, because only that way we can see that on the long run, the CONELOG screw line worked very well, and we will really, or we presume that CONELOG progressive line will perform as good because all the ingredients are there.
Sure.
We have some questions from the audience,
Perfect.
which
That's
I would
good.
like to ask you. And one question is, for instance, how did the patient manage to clean the triangular area between the distal tooth and the implant after 84 months follow-up case with an angulated distal molar? Because the clinician is telling us that he ends up always with foot impaction and then related bone loss. So how do you manage?
Well, here there are several aspects. For sure that when we treat and rehabilitate patients, we have to be aware that the supportive, in this case, peri-implant care is mandatory. And this means that the patient has to come to our office according to the individual risk factors. This means that if you have a problem for being clean in that posterior area, it has to come to our office probably more often. However, having said this, if the patient has problems in that zone, we have to solve them. And sometimes we have, or we can polish a little bit the mesial aspect of that distal molar to have a flat wall. In that case, we can have a better contact point, avoiding the impact, the foot impactation. And also to use, the patient has to know how to use the interproximal toothbrush also. And the last situation is to extract the distal tooth. That is the last. And we think and we should avoid that clinical situation. So characterizing individually our patient in supportive periodontal care, in this case pre-implant care, is very, very important. And also consider that prosthetical aspect in terms of having a better contact point in that particular zone.
So patient compliance is crucial, no? Otherwise,
Sure.
that's
Sure.
an important point.
In fact, Michael, today, this kind of studies, this is an important question, because this kind of studies should cover the patient's related outcome measurements, because the long term of the implants can be very nice in terms of survival, success rate, but the patient can be uncomfortable because foot impactation, for example, in that case. However, having said this, again, it's important to check that in those places, we are able to keep the bone. Not only us, but also the patient. And this is the important issue. However, if the patient is not comfortable, we have to do something.
Yeah, so you have to evaluate the patient, and then according to the patient, you will choose the treatment options, no?
Individually.
Yeah.
Sure.
Thank you. Perfectly answered that question. Then there's another question. Why don't you use, instead of the comfort bar abutments, the tie base? You know, we have a tie base of 2 millimeter height. So why do you not use this option, for instance, was one question.
Let me know something. This tie base abutment can be installed at the same time in the surgery or not?
Well,
you have to work with this time-based abutment in the lab. Am I right or not?
Exactly. You have to actually extraorally, you will bond the hybrid abutment or hybrid crown on top of the abutment, which actually answers already your question, because one abutment, one time is not possible. Otherwise,
but another problem is that, do you take the impression to the abutment or to the shoulder of the implant?
Well, let's say I know a clinician who uses the one abutment, one time concept using tie bases with always a hybrid abutment in zirconia. So he installs the abutment either day of surgery or maybe 1 day or 2 days after, depending on. Okay. But most of the he tries always to do it exactly the same day. And then what he does, he takes an impression on hybrid abutment level with an impression coping. So the technician will prepare the coping, and then day of impression taking, he places a coping on the hybrid abutment and takes the impression.
If you use it in that way, probably you can use it.
Yeah. Yeah, he has very good results actually using this technique.
But another next question. The questions come from me to you now.
Good.
Next question. Imagine because life is long. How long are those implants be placed in that patient? Imagine 15 years, 20 years. Do you think that that prosthesis that is placed on titanium-based abutments need or will need to be taken off for cleaning?
That's a good question. Yeah, you can intervene, of course, every time. No, you can remove the restoration.
That appears with a mucositis or a periodontitis in 10 years, 15 years.
Yeah.
You have to extract everything. And if you extract everything, you are going to extract the abutments also. However, if you have an intermediate abutment, such as the CONELOG, with the CONELOG connection, this 7.5 degrees of connection, that is perfectly fit, as you know, because the studies, if you retrieve the prosthesis, the abutments are still there.
Yeah.
And you can clean the prosthesis without affecting the attachment of the soft tissue.
Yeah, that's probably the difference as well, let's say, between the, in Germany, the majority of the restorations still today are cemented, probably 70% of the restorations.
Yeah.
And of course, we know that in Spain, you have the culture exactly. I mean,
Opposite.
90% probably of the restorations are screw retained. So it's a completely different culture as well. But I know that he has excellent long-term results. But of course, patient compliance has to be, everything has to follow actually in order to make sure that on the long run, they will work as well. But of course, the discussion is quite often then zirconia in contact with the soft tissues. Nowadays, we hear a lot about the positive, actually, plaque prevention, less peri-implantitis apparently, and so the favorable conditions a zirconia abutment may provide to the surrounding tissues. That's a discussion. Sure. There's another question, Juan, as well, coming from a participant. Why you use connected crowns or splinted crowns on two adjacent implants, actually, instead of leaving them, single units?
You are talking about the study?
The study, exactly, in the study.
The study was the study. There were inclusion criteria, and the inclusion criteria were, as you saw in the X-rays. That's one. Second, we can go for individually crowns. Why not? Depending on the length of the implants. You can go for both situations, clinical situations. If you have 2 units, 2 implants, you can go individually and also connected. Why not? Why not connected?
Yeah, you have a better force distribution on the load,
yes.
Of course, on the implants. Yeah. Then another question is, so you used both CONELOG screw line and CONELOG progressive line. Do you nowadays use in all indications CONELOG progressive line, or are there still indications when you would probably rather place a CONELOG screw line implant?
Today, I only use progressive line.
Okay.
And the reason is very simple. It's because the indications for these implants can be all around the mouth. No problem at all with the different clinical situations and the different indications. And also it's a matter of ergonomy, to have the less material as possible. Otherwise, you have in your office plenty of different screws, different
instruments. You need different instruments,
devices, and for me, it's important to be in my private office very fast and to have protocols, clear protocols to establish a routine in the team, and go for the progressive line in boom, 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 everything goes very fast.
So the conclusion would be then for me as well that you use progressive line in all different types of indications.
Sure.
So we saw single units, we saw the full mouth upper jaw as well, where you placed multiple implants. So in the mandible,
inhalation, immediate loading, sinus lift, every indication.
And even dense bone.
Sure. The only difference is that if you have dense bones, all the implants, not only the progressive line, all the implants, you have to understand the characteristics of the implants. Otherwise, it's very difficult that you understand how to proceed in a soft bone, in a medium soft bone, or in a hard bone. You need to understand the length of the threads, the distance of the threads, the shape of the threads, and also the geometry of the implants, because with these implants, clearly we are going to have a better primary stability in soft bone. How we should proceed in dense bone? Probably we need to drill more. And as you know, there is a drill that enlarges the osteopreparation, the hole for receiving that implant. In those cases, you have to go in that way.
Thank you very much. Super. Very, very interesting and very comprehensive presentation, Juan. Now we are in Switzerland. It is 7:30, so perfect timing as well. And from my side, and I think all the participants, we really thank you very much for your presentation, for your time. I think everybody learned something tonight and everything evidence-based, but maybe one final comment. What is really interesting was that we showed the studies, the multi-center studies, which were done at universities, where we know that patients' compliance, follow-up, everything is probably better. And then the studies in private clinics, where the results were very, very similar. And we know that their patient compliance is probably not as good as at the university, no?
Sure.
So my conclusion would be, it's not only at the universities that our system may work well, even in the private clinics. Huh?
Well, this type of studies, the non-interventional studies, are very important.
Yeah.
Probably from a evidence point of view, is not the top. But before you have the RCTs, proving the efficacy of the product, and then you need the effectivity. And this means that a product can be used for everybody in the different clinical scenarios in the private setup. And these are the non-interventional studies. And these are very important studies afterwards.
Juan, I just received one final question from Georgia, and this will be really the final one, which was, good evening, Mr. Blanco. Good evening, Michael. Greetings from Georgia. What is the main reason of marginal bone recession when using healing abutments?
Well, first of all, the way you treat the implant, you install the implant. Second, when you use healing abutments, clearly to go for the final prosthesis, you have to connect and disconnect there several times, the healing abutment. Also, you have to take the impression to the shoulder of the implant. And this is not the good way, because the implant always has to be inside of the bone. And if you several times connect and disconnect, the epithelium is going to downgrowth. If the epithelium downgrowth, clearly you are going to have bone resorption. This is the difference with one time, one abutment. The only problem is that we don't know how many times is allowed to connect and disconnect. This is another problem.
Well, so this is now the conclusion of our webinar with Professor Juan Blanco from Santiago de Compostela on the clinical advantages of platform switch CONELOG implants with the promote surface and the deep conical connection. You showed all the evidence and your clinical experience. Juan, we say thank you very much. Wish you a wonderful evening. Say thank you very much to all participants from all over the world who actually spent the time with us. And I hope we will see you very soon again. So bye-bye from Basel. Juan, thank you very much.
Santiago de Compostela.
Adios.
Adios.
Thank you very much. Bye-bye.